Why don't we move next to Dr. Brautigan. Dr. Brautigan is in private practice in Ohio, and he's been a longtime tunneling expert and has taught many people how to utilize transosseous tunneling. So we can benefit from his input here. Take it away, Brad.
Thanks, Brett. So, Mark, that was a great talk. Uma's talk was very good as well, and Brett, your intro was fantastic. So there's not a whole lot of room here, but I come at this from a private practice perspective. I have ownership in a surgery center, and I'm definitely involved in cost containment and trying to reduce the amount of spend that we have per case because it affects our bottom line. That definitely makes us a little bit more intimately involved in the cost per case. So I'll come at it more from the private practice perspective, and also I have been doing this for a while. My history with transosseous repair, starts with, just learning rotator cuff repair as a resident at Akron City Hospital. I worked with Rob Bell, who was just starting to transition to arthroscopic rotator cuff repair with anchors. I did a sports medicine fellowship at the University of Kentucky, and we did 99% knees. And so there wasn't much going on for that year with regard to the shoulder. But in practice, I went and visited Gary Gartzman. He had like a weekend fellowship type of offering, and in a 2-day clinic that was very well organized. He taught me how to do arthroscopic rotator cuff repair. It was really exceptionally well done, and it makes me feel optimistic that anyone who would want to learn how to do this technique. Now, Gary taught me how to do it with anchors, but I feel the same methodology that Gary used to teach those of us who wanted to transition to arthroscopic rotator cuff. Those same steps and techniques of teaching, I think, are applicable to this methodology. And it can be that quick. I came back from a 2-day clinic with Gary and just got right into it, and I haven't looked back. From there, I was a arthro tunneler test site surgeon, and we started off with a device that looked much like the tensor device, in that it was a reusable device. It was heavy, it was sturdy, it felt great in your hands. And then after the testing was over, they went to the disposable, and I've been an arthro tunneler user since the beginning. And according to Tournier, I was using the tunneler. I was second place only to Butch Krishdon as far as use of the device. So I've been doing this for a while, using this type of technique. I started to use the tensor device, and there are some differences between the tensor device and the arthro tunneler. The tensor device is far more sturdy in your hands. It's far more predictable with regard to the initial pass of the suture through the device to the eyelet. So it is more efficient in my operating room compared to the arthro tunneler. Both get the job done, but the tensor device does have some advantages. My experience from the other side is that I had a rotator cuff repair and a biceps tenodesis. It was done by Butch. I had it about 1.5 years ago. So that meant I had to fly to Texas to have my rotator cuff done from Ohio, and it was well worth the trip, I can tell you. I've had a fantastic outcome, and I'm a believer. So why would we use this technique? I think everyone has touched on this. The transosseous technique is the gold standard. You can use it open or arthroscopic. For those of you who are still doing open cases, there's no shame in that, but this technique is still applicable to that. The reduction in cost is dramatic, and I'm intimately involved with looking at these numbers, and a break-even point traditionally has always been discussed at like 1.5 anchors is the equivalent of using an arthro tunneler for many years, and I've looked at it with the tensor device, and it's between 1.5 and 2 anchors. So anytime you're, and that's average anchor price. So if you're looking at an average anchor price of, anywhere from $250 to $325, once you get beyond 1.5 to 2 anchors, you're spending more than you would if you were using the tensor methodology. The biologic advantages, I think, are undersold, really. I think venting the greater tuberosity and having access to the bone marrow is a tremendous benefit with this technique. I don't think we talk about it enough, quite frankly. It reduces the pressure head within the humeral head, and my patients have far less pain postoperatively than my partners who use anchors. I think the reduction in pain is from the venting and from the reduction of the pressure head. The marrow venting right into the site where you need the bone marrow is just a tremendous advantage. And I've had, actually, I haven't looked at the numbers, but I am not afraid of repairing a smoker because of this technique. I don't have large failures at all, really, but I don't have large failures specifically with smokers. I try to get them to quit, but because of the biologic advantages, I think it actually overcomes some of the disadvantages of working on a smoker. The other thing that, as far as cost containment, if you're doing a biceps tenodesis in the same case, you don't need a separate anchor or fixation device. You can use the Transosseous technique. The tensor device and versus the arthrotunnel, again, I think it's a little bit more sturdy in your hands and much more predictable in that passage of the suture through the device. Once you pass it into place, I haven't missed yet. The suture might drop once in a while, but I haven't missed actually getting the pin to go right into the eyelet on every pass. So that's helpful because we don't want to pass through the greater tuberosity any more than we have to. I like simple sutures. I don't like complex constructs or ripstop sutures. Gary impressed upon me the fact that we want physiologic tension. He impressed upon me that we're soft tissue surgeons. There has to be some touch, some feel. Simple sutures with knot tying is all that's really required. If you need additional fixation, you use an additional suture. I don't think we need terribly complex patterns to get a good result. I think if you use simple sutures, you leave the cuff in a position where it can find its home. So if it is a little bit over tensioned, it can pull back just a little bit and find the appropriate tension for healing. If you use ripstops and if you try to lock that thing down at time 0 with maximum tension, you're a setup for failure that way. Gary he actually liked Ethibond for rotator cuff repairs. And I asked him why, because we had better sutures at the time. And he said he liked the fact that if he was tying the knot too tight, it would break. So he never over tensioned a rotator cuff. So with some of the stiffer sutures that we use, I think we have to be really careful about how much tension we're using when we tie them down. I thought that stuck with me for a long time. And this picture of the Lilliputians holding down the giant with just simple ropes and ties, all they had to do was add suture. So we've seen this slide before. This is one of Mark's slides, and my repairs look very similar to the repair that you see on the left. I have used augments like Mark does, and the grommets that you see there on the lateral side of the repair. I've used that. Tournier came out with a grommet technique, and there was a question already in the chat room about what do you do with bad bone. So what do I do with bad bone? I don't use grommets. I really don't. I use maybe a few more sutures, and what I do is I make sure that I balance out the tension with each of those sutures as I'm tying so that I'm not overloading any individual suture. I use a physiologic tension with each suture, and if I use multiple sutures with low tension or physiologic tension, if is probably a better term, but lower tension for bad bone, then you're not going to have a bony failure or a cutout. I've been doing this for a while, I have not seen that problem in my patients. And I always check my lateral tunnel to make sure that I don't have cutout. That's a checkpoint for me after I finish the fixation. I'll look at the cuff and then I'll put the scope in from the lateral side and I'll look directly into those passage points to make sure that I don't have cutout. So I thought I'd show you guys a case that I did yesterday. I took lots of pictures. So this is going to be a rotator cuff repair and a biceps tenodesis. And this is one method by which I do the tenodesis. There are a couple of methods. Brett has some really brilliant videos of his method using fixation that he does in the groove. I actually am going to fix this biceps to the tuberosity. So this is what I saw yesterday. I think all of us see this quite a bit. One of the reasons I don't like screw fixation for a biceps like this is that with the biceps being a little beat up and frayed, sometimes during the passage of a screw, you traumatically transect through the biceps. So I'd much prefer to have suture fixation here. So I'm just going to debride the biceps a bit, debride the rotator cuff. I'm looking at the footprint that I want to bring the cuff back to very directly here. So I'm going to take advantage of that. I'm going to create a little bit of exposed bone for my biceps to come back to and the cuff. And then I'm going to create my transosseous tunnel while looking from the articular side of the tear. And I've punched through the greater tuberosity to initiate my transosseous tunnel. And you can see my transosseous tunnel. There's a little bubble. There's a little fat coming up from the marrow. And the tunnel's ideally positioned. Now I'm going to suture my biceps tendon. And I want to have a good suture through the biceps tendon with a locking technique. And so after I pass it with my nitinol needle passer, I'm going to make some passes around the biceps and create a locking stitch. Then when I pull the biceps tendon back through the rotator cuff tear, I'm going to see where that biceps tendon is going to end up once I pass that suture through the transosseous tunnel. It's going to get tucked in right there, and my cuff repair is going to come down around that. From here, I'm going to go to the subacromial space. I've done my decompression of my distal clavicle excision, and now I'm passing my suture with a tensor device. Now I'm passing my suture through the cuff. I've got 3 sutures for my cuff repair. And the knot that you see there is tied down on the lateral side. That was my bicep suture that I passed transosseously. I pull the biceps into the repair site and tie it down with the lateral knot. It was a small tear. I tried to peek in through the rotator cuff tear to see the biceps parked in there. I can see my knot. It's parked exactly where I want it. It's right on top of my transosseous tunnel. I've got my rotator cuff sutures already passed. Those sutures are passed on the medial side of the biceps. So as I tie these sutures down, they'll provide additional fixation for the tenodesis as well. So I'm just tying simple knots, and this is a little nod to Gary. You know, I'm a believer in knot tying. I think it gives us the feel that we need to apply physiologic tension or the appropriate tension to our cuff repair. I know there's a need for knotless out there with some surgeons, but I'm a believer in knot tying. And I think, you know, the appropriate tension you hold down on the post as you pass your knots is a feel thing and something that you really need to try to pass on to those that you teach. But with a revo knot where you're passing 2 similar half hitches down on the same post, and then an alternating half hitch on the same post, and then finally alternating half hitch on a switched post. So I've switched the post by pass pointing, and I need to maintain that pass point as I take that half hitch down. My knot's done. So there were some questions about stack impingement or knot impingement within the subacromial space. I really think that if you sequence 4 half hitches and you do it in the proper sequence, and you get an alternating half hitch with an alternating post as your last half hitch, you're going to have a knot that looks like that. It's not going to go anywhere. It's relatively small in profile. And I really don't have an issue with stack impingement. Maybe first 6 weeks, perhaps there's a little bit of crepitance, but after that, there's not an issue with that. So this is 3 sutures tying down the cuff. And we're seeing bone marrow coming up. We're seeing some of the biology coming up right into the repair site. And again, I always look from the lateral side to check my exit point from the bone. And I think you can see the rotator cuff looks a little mounded up there because my biceps is captured underneath of that as well. And the other point to this is that the blood supply through the cuff comes from medial to lateral. And I've got plenty of room for the blood supply to come in from medial to lateral through the cuff tissue. I don't have it closed off with a horizontal type of method or a ripstop. I'm sure Mark has numerous outcomes on his methodology and how it works. I'm just a believer that you can do this with simple suturing techniques. It certainly makes it a lot more simple for those transitioning to this technique, and it does get the job done. I had some additional slides on cost, but we've already discussed that. Again, the break-even point typically has been about 1.5 anchors to 1.5 to 2, and the cost is I believe Brett gave me a number of $520 per kit, depending on the number of cases that you do. And again, anchors are somewhere in the neighborhood of $250 to $325 just as an average, and those numbers fluctuate. I can tell you if you have a rep who's opening boxes in the back of the room and you're not terribly aware of what those boxes are, that can get really expensive. And if we're gonna start really working toward being organized for bundle payments and getting ready for direct contracting, which is something that I'm very excited about, I can very aggressively go to an employer or to a large group and discuss direct contracting for rotator cuff repairs as a carve out. And I'm in the game because of the cost containment here. And if you're part of a surgery center or part of a group that is managing a hospital perhaps, this cost containment is going to be very, very meaningful. So I can do everything from a small rotator cuff repair to a massive repair. And my cost doesn't fluctuate except for maybe the need for additional suture. Now with the tensor kit, you get 6 sutures. I can do a tenodesis and a cuff repair with that. I can do a large to massive cuff repair with that. There's no issue. So my cost is very much contained. If I need an additional suture, so be it. It's not that expensive. But cost containment is here. The need for it is here. And we all have to be aware of that, whether we're academic or private. The downward pressures on reimbursement are very, very significant. I can tell you that the CMS reimbursement for total knee replacement at ambulatory surgery centers should be a warning to all of us where CMS would like to go with reimbursement. The private pays are going to follow CMS in that payment model. That's going to be really, really difficult on the bottom line. That's been a dramatic reduction in our reimbursement for total knee replacement. So I know AUKUS is holding off on total hips following suit. They're not going to have the total hip reimbursement follow suit with total knee. And I don't blame them for that. I think the pushback is necessary, but the dramatic reduction in total knee reimbursement should be a warning shot to all of us that we really need to be careful about our cost per case. And not only do we get to stratify and maintain our cost per case very evenly with rotator cuff repair using this technique, but we get all of the benefits of the fixation method and the biology and the reduction of pain. It's hard for me to understand, and I know Brett and I have talked about this quite a bit. It's hard for me to understand why people haven't transitioned to this. There are just so many benefits and really no downside. I know that some are intimidated by the technique and they don't really feel like, they were trained on anchors and anchors are easier and all of those things. I did a weekend fellowship with Gary Gartzman, and I never looked back. I know that teaching other surgeons using the same methods that Gary used is very doable. So I will stop there.
Great, thanks, Brad. A lot of good insights there from private practice, and we appreciate your input.